سعيد وشرفني ان انا اقدم الاستاذ دكتور طارق الباز، الاستاذ دكتور طارق الباز استاذ امراض الكلى ورئيس وحده الكلى في طب الازهر، ورئيس الجمعيه المصريه لامراض الكلى، وفي الفتره اللي هو شارك بها في رئاسه الجمعيه اصل الجمعيه وقدر ينجح امام الفريق. الفريق ده متعاون ومتداخل وبيربطه بالحب وعمل اصرار فعلا للجمعيه المصريه، فبنهني حضرتك لان بصمه سعادتك واضحه جدا جدا جدا. حضرتك النهارده اتكلمنا عن الكدني المرض والميلوما، اتفضل.
مستر شاهد، شكرا جزيلا للدكتور حسين. سو هابي ان انا اشوف الاستاذ الدكتور ناجي عبد الهادي ولونج تايم فريند. كل شرف ان انا اكون في اسم البطل في جامعه المنصوره لاول مره. انا باجي المنصوره كتير في مركز امراض الكلى، ولكن الحقيقه اول مره اتشرف ان انا اكون هنا في اسم البطل. really happy and honored, and I feel ان انا في بيتي وسط الامراض البطنه واحنا كلنا امراض بطنه. I'm going to talk today about the kidney, how the kidney is affected in multiple myeloma. Just to remind everybody that plasma cells are responsible about producing the immunoglobulins that we need to fight infection, and at times these immunoglobulins as well are attacking specific proteins in the body, causing autoimmune disease. As a reminder to everybody, this is what the immunoglobulin looks like. It's composed of two heavy chains and two light chains. And the terminal part of the antibody is known as the variable region, or the antigen binding fragment, and these light chains are what are supposed to cause the multiple myeloma, and these variable chains are usually set from the beginning according to our genetic structure, whether they are kappa or lambda, and the relation is 9:1. The other terminal part is the crystalline part of the antibody that is responsible about opsonization and complement activation. Now sometimes the myeloma, the plasma cells are diseased and they are transformed into malignant cells, and they start to produce excessive amounts of antibodies, but not a complete antibody. It's immature and too much. And this is what causes disease, as I will show in a while. So by definition, the multiple myeloma is a malignant proliferation of the plasma cells derived from a single clone, and it accounts for about 10% of all dermatological malignancies. Various etiologies are there that led to this malignant transformation, such as mutations in the oncogenes, familial causes, and there is an important role for interleukin-6, which I will come to describe in the coming slides. As with all diseases, there is incidences for the occurrence of this disease. Here we find it's more in males and in blacks more than whites. So this is regarding the natural history of the disease. Usually patients would present by bone pains in the majority of patients, and 70% of these pains are related to movement, and naturally it's due to the osteolytic lesions that are so common in this disease. And not uncommonly, patients would also have pathological fractures, and this is due to the activation of osteoclast by osteoclast activation factors produced by these malignant cells. Although they have a lot of immunoglobulins, yet, as I said, these immunoglobulins are immature, not proper, so there is hypogammaglobulinemia and great precipitation for infectious diseases goes on, and these patients are susceptible to various pathogens causing pneumonias and so forth. Clinical manifestations, I have classified them into common and less common. The common forms would be related to the osteolytic lesions affecting the bone, leading to bone pains and fractures and so forth. And the infections, again, are so common in these patients. And what I'm here today is to address the renal impairment that is a complication of the multiple myeloma. The less common clinical manifestations are related to the acute hypercalcemia and hyperviscosity syndrome, because there's a lot of proteins, and this hyperviscosity syndrome could be associated with various ischemic-related lesions, whether affecting the central nervous system or the nerves. Also, coagulopathies are known to occur in multiple myeloma. Now, renal failure, which is a dreaded complication of this disease, occurs in about 25% of patients, and hypercalcemia and hyperuricemia, which occurs with various types of malignancies, may be a contributing factor together with tubular damage, whether due to the light chain deposition that I will come to explain shortly, or whether due to the presence of the hypercalcemia. Anemia is also a salient feature in the disease, and it is of the normochromic normocytic type, and we may have depression or myelophysis of the blood-forming elements in the bone marrow, leading to a sort of bone marrow failure. And in the advanced cases, we may face patients with leukopenia and thrombocytopenia as well. Looking to the bone disease, we find athletic lesions are not uncommon in about 60% of patients, who would also have osteoporosis due to the osteolytic lesions and the continuous demineralization of bone, leading to compression fractures. And if you look to the bone marrow, you will find an increase in the cellularity with abundance of these malignant plasma cells within the bone marrow. A reminder of what the osteolytic lesions would look like in that humerus on the left-hand side, with a pathological fracture as well. And the right-hand side shows a compressed fracture affecting the spine. Here is a part of a bone that has been diseased. This is the normal-looking bone, this is a healthy bone, and this is the diseased bone. It looks so unhealthy due to the presence of the myeloma cells. And this is where the site, of pathological fracture occurred. Again, this is what the osteolytic lesions would look like in the vault of a deceased patient with multiple myeloma, and maybe before he died, he took this lateral X-ray to show the classical punched out areas present in his skull. And radiology is a very important part in diagnosing this disease, and we should use it to screen susceptible patients. And I would advise to have a lateral skull X-ray, and maybe for the hands as well, whenever you have a clinical hunch or suspicion about multiple myeloma. There could be also some minimal diagnostic criteria that we use to diagnose. If you examine the bone marrow, you would find more than 10% plasma cells, and this is enough to warrant suspicions for this disease, together with the classical M-band on examination by immunoelectrophoresis. Urine, it is historical, but if we have a significant amount of light chains in the urine, you will find the vegetables proteins on examination. Coming to the kidney and how it is affected, the kidney can be affected in various ways. Volume depletion leading to a pre-renal shutdown would happen due to hypercalcemia, which is clinically associated by polyuria and polydipsia. These patients being so sick and ill and having infection, maybe nauseated and vomiting, so this is another source of losing blood volume, leading to a pre-renal shutdown. Maybe with bone pains, these patients would be needing a lot of analgesia, and a doctor would be giving them non-steroidal anti-inflammatory drugs, which is very serious to these patients, leading to medullary vasoconstriction and acute tubular necrosis. If a patient has a very high level of free light chains in his circulation. This could lead to the hyperviscosity syndrome, which again could cause an ischemic tubular necrosis. Occasionally, such patients having hypercalcemia or hyperuricemia may have an actual mechanical obstruction of the renal tubule, leading again to acute kidney injury, or that actually it could be calculi related to these crystals which could be present in abundance. Patients usually present with a serum creatinine of 1.5 to 2 milligrams per deciliter, and the higher serum creatinine denotes that the prognosis is not all that good, particularly for patients who develop acute kidney injury and need dialysis. The prognosis is worse for those patients. The causes of renal failure in multiple myeloma are various, and I will address each separately. We could have nephropathy, light chain deposition disease, primary amyloidosis, hypercalcemia, renal tubular dysfunction, and complications related to the volume depletion, and particularly if you are going to use an IV contrast dye, you shouldn't do that for these patients, and naturally should avoid nephrotoxic agents and non-steroidal drugs as analgesic should be on top of the list. The pathology is also variable according to the etiologies that lead to renal impairment. We find that on top of the list, the famous myeloma kidney is the most common presentation or affection of the kidney. And then we have interstitial nephrosis, nephritis with fibrosis, and this inflammatory reaction occurs due to the uptake of the light chains within the interstitium of the kidney when there is a heavy load within the renal tubules. Amyloidosis is not unfrequent, and it occurs about 10% of patients, and light chain deposition disease, acute tubular necrosis, and other etiologies that cause renal pathology are related to the excessive urate formations and hypercalcemia. So we have two main pathogenetic mechanisms affecting the kidney in multiple myeloma. We may have the intracellular cast formation to the left-hand side. You see that classical cast. This cast is famous because any pathologist or nephrologist who would look at this slide can readily diagnose the disease because it is fractured. It is very rigid. The proteins make it rigid, and as it passes through the convoluted tubules, it gets fractured. Contributing factors that may occur to the presence of renal failure are the high rate of light chain excretion, and this is what is known as a tumor load. If the tumor load is high and the malignancy is so aggressive, you will have a lot of free light chains leading to a more serious condition. Also, the biochemical characteristics of the light chains, which is, has been shown that the kappa chains carry a higher degree of complications. So nephropathy is the most common pathological diagnosis on renal biopsy in a case with multiple myeloma, but is, of course, is not the only pathology that could be found. And I have mentioned that it is due to the combination of the light chains, which are kappa mostly, combined together or bound together with the TAM-horse fat mucoprotein secreted at the loop of Henle. And this together forms the cast. Occasionally there could be a multinucleated cells surrounding these casts, and this is helpful in diagnosing this entity. And this is just to show you what the multinucleated cell looks like, quite near to the cast, where the arrow is. If we do an immunofluorescence, you can see the immunoglobulin G staining by the immunofluorescence in this slide. So this is another way to diagnose the casts by histopathology. Another disease entity that happens in multiple myeloma is related to the deposition of the light chains within the basement membrane of the renal tubules. And this is usually happening with the kappa form of the immunoglobulin fragments, which are related to immunoglobulin G3 in particular. These circulating light chains are taken up by the renal tubules and are deposited, as you can see in this slide, through the brush borders and deposited at the basement membrane. There's a special or specialized receptor called Tubular that uptakes these light chains. Once they are there, they initiate an inflammatory reaction and destroy the renal tubules, causing acute kidney injury, and sometimes there is an influx within the interstitium leading to an acute interstitial nephritis. The right plate shows an electron microscopy where the light chains are deposited in the basement membrane of the tubular cells, and the strange looking slide that looks like diabetic glomerulosclerosis is another entity related to multiple myeloma, yet this occurs in the elderly, and it is due to the deposition of immunoglobulins, but here the heavy chains, which is a very uncommon form of presentation. I put this slide because there's a very close resemblance. Any pathologist would look at it initially could say that this is diabetic glomerulosclerosis, and it is glomerulosclerosis as a matter of fact, but the periodic acid sheaf positive staining material here is immunoglobulin, not like in diabetic nephropathy, and if you look at it by immunofluorescence, you can tell the difference. Amyloidosis does occur in about 10%, and some authors even say that it is present in 30% of patients who present with multiple myeloma, and conversely, and strange enough, multiple myeloma is present in up to 20% of patients who present initially with DA and amyloidosis. Now, these patients present with heavy proteinuria, surpassing the usual ranges in a nephrotic syndrome, yet they would manifest by edema like any nephrotic syndrome patient. Usually, the amyloid is due to the lambda and not the kappa as the light chain disease. It is due to lambda fragments or chains, and the pathogenesis is quite similar to what occurs in the light chain disease, but it is lambda and not kappa in this condition. And if you have a look at the pathology by electron microscopy, you could see the classical appearance of the fibrils of the amyloid, which are pleated, and to the left-hand side, you can find the deposition of the amyloid within the mesangium, and by polarized light, it will give the classical green birefringence. Hypercalcemia is not uncommon to happen in multiple myeloma, but don't expect it to be, and don't miss a patient. I mean, don't miss diagnosis of the patient because he's not hypercalcemic, but it does happen. Hypercalcemia occurs, yes, and you get levels of serum calcium more than 11 and even higher than that, and it is a contributing factor to the recurrence of acute kidney injury due to the vasoconstrictions that may happen in the medullary vessels, or due to the crystallization of these crystals causing stones, or sometimes influx again into the interstitium through the renal tubules, initiating acute inflammatory reaction within the renal interstitium. One of the rare presentations related to multiple myeloma and commonly occurs with the kappa light chains is it may cause a renal tubular acidosis of the Fancont type. And this is not very common, but it does happen. And mind you, these patients, when you examine them for albuminuria, you don't find albumin because it is a non-selective proteinuria. So don't miss a case because you examine for albumin, but if you check for proteins, because mainly they're immunoglobulins, of course, you will have heavy proteinuria. In this form of injury, the tubular damage due to light chain toxic effects or indirectly from the release of intracellular lysosome, and this presents, as I said, as Fancont with the characteristic renal tubular acidosis of caluresis, phosphaturia, uric acid in abundance in the urine, and wasting of the bicarbonate in the urine as well. I still wanted just to remind you that with all these entities I've been addressing, yet the two main pathogenetic mechanisms for renal affection would always be intracellular cast formation or direct tubular toxicity by the free-flowing light chains. I've been talking initially about the role of interleukin-6, which is an important growth factor for the plasma cells in this disease and plays an important role as it stimulates acute phase reactions from the liver, which could promote cast formation and sometimes impair the light chain resorption. Also, it contributes to hypercalcemia by stimulating osteoclast, not only stimulation of osteoclast, but also depressing the action of osteoblasts. So interleukin-6 is quite an important cytokine in this disease entity. The last part of my talk would be related to treatment. I'm not a hematologist, so I'm not going to address the details of treatment, yet general lines. Hydration is very important, but if you have a patient with hypercalcemia, it is something very important to give fluids, but always be wise, don't push too much fluids for fear of pulmonary edema. Treatment of hypercalcemia is hydration. You would use diuretics, but I would advise against bisphosphonates because they are extremely nephrotoxic. And these patients usually have renal impairment and will be susceptible to complications related to the bisphosphonates. The classical treatment of myeloma is using steroids and thalidomide and vincristine and guanidinoline. But lately, one of the good lines for treatment is to use the autologous stem cell therapy, but the patient has to go through courses of chemotherapy before that. Sometimes we may resort to plasmapheresis, I will address shortly now, and dialysis if a patient has acute kidney injury. I'd like just to update you about new modalities of treatment, and this new drug, the bortezomib, has been shown to be remarkable in treating multiple myeloma. Not only multiple myeloma, it's been used in mantle cell lymphoma and other non-Hodgkin lymphomas. It's a proteasome inhibitor which arrests the cell cycle, and it is reversible, so it's not going to cause a lot of damage. This is the trade name for it, Velcade. So there's a lot of publication nowadays about bortezomib and its effect in saving the lives of these patients. Plasmapheresis, just like to say that theoretically it is quite beneficial to remove these toxic substances, which are the light chains, to spare renal function. But the light chains are not only in the circulation, they are elsewhere. They are present inside interstitial fluid, and you have the malignant cells that are producing them all the time. And when we apply plasmapheresis to our patient, this may lead also to removal of coagulation factors, because plasmapheresis removes large-sized molecules, and among them would be the coagulation factors. Once this patient needs dialysis, he may be subjected to bleeding tendencies. This graph will show the effect of plasmapheresis on the M bands. To the right-hand side, you can see the immunoglobulins with the classical M band, and to the left-hand side, you can see the effect of treatment on decreasing these levels. Once again, I remind you that the pathology is related to the free light chains present in the circulation that may be deposited within the basement membrane of the renal tubules, or the formation of cast nephropathy that has both a mechanical obstructive tendency as well as a direct toxicity to the renal tubules. So what are we going to do? The plasma exchange doesn't work all that well. Even regular dialysis is not a cure. Maybe it helps in ameliorating symptoms related to the acute kidney injury, but again, it's not a cure. So until now, there has been little success in attempts to use blood purification, and I'm referring to the plasmapheresis, but perhaps, perhaps there could be a renal rescue for myeloma patients. And I just want to tell you about the Theralite, which is a high cutoff technology. They have produced these very new membranes since a few years now. These pores are very large and are able to remove the free light chains in the circulation, and they have been, there has been publications to show how effective they are. Of course, you have to couple using these dialyzers together with chemotherapy. They are not a cure. You are only removing the light chains to save the kidney. And right now, there's a mega trial going on in Europe. I don't have any initial data to tell you about. We are all waiting the results of this trial. These membranes seem to be effective in removing the light chains, yes, but as always, new technologies and new medications are very expensive. The hollow fiber would cost around €1,000. A patient would need 6 to 10 treatments, yet it is promising. Maybe with advances of this technology could go cheaper. As such, ladies and gentlemen, to prevent renal failure and multiple myeloma, I'm concluding to say that you have to do all you can to hydrate the patient and discontinue any nephrotoxic agents and promptly start to treat chemotherapy with our colleagues, the hematologists. And to treat multiple myeloma also, we could apply methods to remove the light chains. I thank you all and my talk with these beautiful images from your wonderful city, Mansour. Thank you very much.
Thanks so much for this elegant presentation as usual, and very illustrative, and I think there is time for a few questions. أسئلة يا جماعة، في أسئلة. سؤال صغير بالنسبه للبلازما فريسيس، عاوز حضرتك توضح الدور بتاع البلازما فريسيس تاني، لان في ناس يعني بتريكومند البلازما فريسيس، وايه الانديكيشن من وجهه نظر حضرتك ان احنا لازم نعمل بلازما فريسيس؟
No one single treatment is a real cure. It's only a trial because you are عمال بتشيل من على الوش. There's always production, so if you are not giving the patient any chemotherapy, it is not effective. Plasmapheresis طريقة تنقية الدم تشيل منها الحاجات اللي انت مش عاوزها نعمله في أمراض كتير جريان very good. لما بنيجي للمالتيبل مايلوما دكتور حسين, the problem is not something that is static, it is continuous formation. There have been a lot of trials, but really the results are disappointing. Yet still people would use it. If you have the ability to use it, if you have the facility to use it, you would use it when you have particular high load of light chains. Maybe that new therapy that I'm addressing is going to prove eventually that it is much more effective in removing the light chains. Yet, as I just said, you have to couple this with chemotherapy to stop the initial disease, the malignant cells that are producing the light chains.
Next question. Patients with multiple myeloma renal failure.
Well, thank you for asking me this question. Prognostically, they are not good candidates to be transplanted, except if you are absolutely sure that you have a remission for a significant time, maybe not less than 2 years. which is very uncommon with this disease. So they are not the patients to be transplanted at all. And whoever did this was really disappointed. The best of grafts did not survive for more than a year. I recall I had a patient who had a fractured cast, and I did everything to try to prove that this patient has multiple myeloma. We had renal failure at the same time, out of the blue. I couldn't tell why. And why is this fractured cast there? You should have a myeloma. When you have a sternal puncture for this patient and you find that the plasma cells are less than 10%, you don't have a really solid evidence to diagnose multiple myeloma with a normal plasma electrophoresis. This patient had what is known as a non-secretory myeloma, and this is really very difficult to diagnose, non-secretory myeloma. He was transplanted and he didn't do well at all, and he passed on an acute kidney injury immediately after transplantation. He was back to dialysis and he lost his graft. 6 months following the transplantation, he had a frank presentation of multiple myeloma. He presented by a fracture, and when we asked for a radiology, the orthopedic, he was astonished to find an X-ray quite similar to the one I showed, the lateral skull and the humerus. So this was a non-secretory multiple myeloma. And that's why I'm stressing on the fact that cast nephropathy is almost the same queen of this disease.
Thank you so much, Professor Tarek, for your presentation. For the sake of the time, we'll move to the next speaker. طبعا next